Stop the 5 routine hospital mistakes that are actually killing seniors. Most seniors trust the routine hospital steps. The top 1% who come home strong do one thing differently. They question them because the hidden cascade is real. 1, just in case test leads to bed rest, then drug changes, then an infection, then rehab you never planned, sometimes with a 5-figure bill. This isn't your fault. The system rewards speed and billing, not recovery and function for older bodies. In the next few minutes, I'll show you 5 routine mistakes you can refuse or rework that can save $50,000 and, more important, protect your independence. Here's the hard number. 14 days in bed equals roughly 20% strength lost, about 1 to 1.5% per day, followed by more falls, memory dips, and new meds you didn't need. Stay with me, because we'll break the 70% drop-off trap, the form you must carry, and the 3 words that flip every decision in your favor. Why this matters now. Older bodies lose ground fast in hospitals. Every day of bed rest strips about 1 to 1.5% of strength, adding up to nearly 20% in 2 weeks. That's the difference between walking to your bathroom and needing 2 people and a walker. Balance, stairs, and reaction time all drop, which means falls rise right when your body is least ready to handle one. Hospitals run on checklists designed for throughput, not senior-specific risks like delirium and sarcopenia. So when a routine box gets ticked, like CT now or Foley for convenience, it can trigger a cascade that older adults pay for with function, not just money. And here's where the numbers get uncomfortable. Unnecessary imaging finds incidentalomas all the time, about 30% of abdominal CTs, and around 10% of brain scans turn up something unrelated to why you came in. It even has a name: vomit, victims of modern imaging technologies. Those harmless findings can push you into more scans, biopsies, bleeds, infections, and yep, more bed rest. Every extra hospital day raises your risks. Infections from lines and catheters, in-hospital falls, and new drugs that don't stop after discharge. One of the quietest traps happens at night. Just 1 dose of a benzodiazepine or a Z drug to help you sleep sounds kind, but sedatives are linked to a high proportion of in-hospital falls and delirium. In some hospitals, more than half of fallers had one of these on board. Delirium alone can double your chance of losing independence, landing in a facility, or not making it back to baseline. There's also a financial cliff that almost no one tells you about while you're in a gown. Medicare's rehab coverage hinges on your status. You need 3 consecutive inpatient midnights. Observation days don't count. Even if you're in the exact same bed, with the exact same nurses, miss that threshold. And a short rehab stay can drop a $10,000 to $50,000 bill on your kitchen table. That's not rare, that's policy. Now, here's the part that should raise your confidence, not your blood pressure. Seniors who come in with a simple 1-page plan ask a few precise questions and anchor every choice to a clear goal cut their length of stay, avoid cascades, and walk out stronger. They don't need medical school. They need a tiny set of scripts and a mindset. If a test, a tube, or a pill won't change today's treatment or help me get home safely, we pause. Before we hit the 5 mistakes, I'll give you that hospital shield game plan so you're protected from minute 1. Pre-game plan, your 1-page hospital shield. Here's your protection you can carry in your wallet. A single page that tells the hospital exactly who you are, what you can do at baseline, and what keeps you safe. At the top, write your full name, date of birth, and 2 phone numbers, your healthcare proxy or power of attorney, and a backup. Under that, list your current medications with doses and timing, plus any allergies and what reaction you had. Don't leave it at nausea or rash. Be specific so they take it seriously. Next, define your baseline function in 1 sentence. For example, walks household distances without a device, climbs 12 stairs with a rail, handles own toileting, uses hearing aids and glasses. This matters because the team often meets you at your worst moment and assumes that's normal. When they know your baseline, every decision can be measured against getting you back to it. Now the goals box. This is where you set the rails. Write 3 to 5 clear outcomes in bold. Home walking like before. Up to a chair for all meals. Walk 3 times a day with assistance. Avoid benzodiazepines. Z drugs, diphenhydramine, hydroxyzine. No Foley catheter unless true urinary retention, surgery, or strict output needed. Prevent delirium. Keep glasses, hearing aids, daylight, quiet nights, and low-dose melatonin only if needed. Add one line that changes everything. Call my advocate before any new test, medication, or tube. Put the phone number right next to it in large print. This makes your loved one part of the team instead of a visitor. Include a status and safety section. Your code status if you've decided it, any fall risks, and special needs like language or cognition. Add a short note. High risk for delirium. Use non-sedating options first. That sentence alone prevents a surprising number of nighttime missteps. Finally, at the bottom, print the 3 words that anchor every choice. What's our goal? Train yourself and your advocate to use it before any CT, MRI, for line, catheter, or sleep medication. Follow it with one of these. Will this result change treatment today? And can we remove it today for any tethers? Print 5 copies. 1 for your wallet, 1 for your refrigerator, 1 in your glove box, 1 saved as a photo on your phone, and 1 for your advocate. When you arrive at the hospital, hand it to Triav, the first nurse, and the admitting team. Then hand it again at shift change. With that shield in place, you're ready to block the first and most expensive trap. Mistake number 1, the just-in-case CT/MRI Cascade. This one starts with good intentions and ends with a biopsy you never needed. Why is just-in-case imaging pushed so fast? 3 reasons. First, liability fear. If something rare is missed, everyone gets blamed. Second, default protocols. Many emergency order sets trigger scans by reflex. Third, quick billables. Imaging is fast, available, and financially aligned. But here's the catch. Older adults pay the price in cascades. Let's make the risk concrete. Incidentalomas, findings unrelated to why you came in, show up on about 30% of abdominal CTs and around 10% of brain scans. There's even a term for the harm that follows. Vomit, victims of modern imaging technologies. A harmless spot becomes a new problem. That means more scans, needles, bleeding risks, infections, and you lying in bed waiting between each step. Bed rest alone costs you about 1 to 1.5% of strength per day, stacking up toward 20% in 2 weeks. That's how a quick look becomes a month of recovery. So what do you say when the tech is already at the door? Start with your shield and the 3 words, what's our goal? Then ask the pivot question, will this result change treatment today? If the answer is no or it's a baseline, you have room to pause. Use the time box rule. If you're stable with no red flags, ask for observation and repeat checks for 6 to 12 hours before scanning. Most chest pain, most belly twinges, most lightheaded episodes declare themselves with serial vitals, a bedside exam, and targeted blood work. Many resolve without radiation, contrast dye, or the bed-locked wait for transport. There's a safer swap that professionals respect. Propose a bedside exam plus repeat vitals at set intervals and a targeted lab panel tied to your symptoms. Example, for dizziness without head trauma, start with orthostatic vitals, hydration, and a careful neuro exam. For vague belly pain without peritonitis, ask for serial abdominal exams, basic labs, and pain control first. For chest tightness with normal EKGs and troponins, continue monitoring and walking trials with assist before a CT. Now, exceptions matter. Do not delay when the window is real. If stroke symptoms started within the treatment window, If there's head trauma with red flags like loss of consciousness, vomiting, or new weakness, or if your belly exam shows peritonitis, severe guarding, and rebound pain, imaging can be life-saving. Your shield isn't a brake, it's a steering wheel. It helps you avoid the default when the default isn't helpful. Here's how the script sounds at the bedside. What's our goal with this scan? If the result won't change what you do today, can we watch for 6 hours with repeat checks? Could we do a targeted exam and labs first? I'm concerned about incidental findings leading to procedures. How do we avoid that if the scan shows something unrelated? This language keeps the team on your side. You're not refusing care. You're aligning care with outcomes. A fast micro-story to lock it in. A 78-year-old with brief chest pressure arrives calm, stable, and pain-free. The default order set includes a CT pulmonary angiogram. Her advocate uses the goal question. The team agrees to serial EKGs and 2 troponins over 3 hours, both normal. She sits up for meals, walks to the bathroom with assistance, and her symptoms don't return. No CT, no dye, no incidental nodule to chase. She sleeps at home that night and avoids a $7,000 observation bill plus a week of scan-related anxiety. But here's where most people mess up. They agree to the scan, then forget the second half, asking how to handle incidental findings if they appear. Before the scan starts, ask the clinician to define thresholds. If you see something unrelated and low risk, can we plan to discuss outpatient follow-up instead of in-hospital procedures? This pre-commitment reduces the chance of an automatic biopsy at 2 a.m. Another mistake is thinking MRI is automatically safer. While there's no ionizing radiation, MRIs still uncover incidental findings and can keep you off your feet for hours. If the MRI requires sedation for claustrophobia, your delirium and fall risks jump. Use the same questions. Will it change today's plan? Are there non-sedating ways to complete it? Can this be outpatient? And one more pivot worth learning. Walk when safe before you scan. If your symptoms ease and your vitals are steady, ask for a supervised hallway walk. It tests real function and can reveal who actually needs more workup. If walking worsens symptoms or drops your pressure, that's useful information. If it doesn't, you've proven stability and often avoided the dominoes. Tie it back to your shield. Hand it over. Use the scripts. Ask for the time box. Agree to immediate imaging only when the benefit is clear and time-sensitive. This one decision point, stopping a reflex scan, can prevent the entire cascade. No bed rest, no catheter for transport convenience, no sedative for an MRI, no surprise incidentaloma, no invasive procedure you never needed. Once you avoid that first domino, everything else gets easier. Mistake number 2, automatic bed rest and Foley catheter. Once that reflex scan is off the table, the next trap shows up quietly. A nurse says, "Let's keep you in bed for now." And someone reaches for a catheter just to make things easier. Easier for whom? Bed rest and Foleys are convenience tools that quietly drain strength and invite infections and confusion, especially in older adults. Remember the hard math. Every day flat costs around 1 to 1.5% of muscle. In a week, stairs feel harder. Reaction time slows. A small stumble becomes a fall. Add a tether like a catheter or an for that never gets removed, and you've cut your chances of getting out of that bed on your terms. Here's why it happens. Hospitals are built for monitoring and speed. Bed alarms, catheters, and NPO after midnight policies reduce staff steps, not fall risk. The problem is that catheters are one of the fastest routes to a urinary tract infection. Infections spike delirium. Delirium drives more sedatives, which spike falls. That's the cascade. More bed rest is not a treatment. It's a risk factor. So make your stance simple and early. Use your hospital shield and say, no Foley unless there's true urinary retention, surgery, or strict hourly output needed for kidney or heart issues. Those are legitimate reasons. Convenience is not. Before any catheter, ask for a bedside bladder scan. It's painless and fast. If the bladder isn't full, you don't need a tube. If it is full and you can't pass urine, then a short-term catheter with a clear plan to remove it within 24 to 48 hours is reasonable. Put a stop date in the order. Next, replace bed rest with a mobility order that reads like a prescription, up to chair for all meals. Walk 3 times per day with assistance. Sit on the edge of bed for teeth brushing and grooming. Ask the nurse to chart ambulation like a vital sign. Steps are data. When walking is on the whiteboard, it becomes part of care, not an afterthought. Request physical therapy and occupational therapy within 24 hours of arrival. Their notes can unlock equipment, home health services, and safe discharge. Now, you might hear they got dizzy when we tried. Good. Now we have a clue to treat. Ask for orthostatic vitals, hydration, and a medication review. Blood pressure drops when you stand. Adjust fluids. Time blood pressure meds earlier in the day. And try again with support. New weakness? Try sit to stands from the chair, marching in place, and heel raises before hallway walking. The goal is progressive mobility, not heroics. Watch for tethers that masquerade as safety. A bed alarm without a plan to mobilize just trains you to stay put. And 4-pole, in case we need it, becomes a leash. Use the script. Can we remove it today? For any line, catheter, or alarm. If the answer is no, ask, what has to change so we can remove it tomorrow? Get that condition on the board. Nighttime is where this trap deepens. Instead of a catheter to avoid bathroom trips, ask for scheduled toileting. Offer assistance every 2 to 3 hours and before lights out. Pair it with a clear path, non-slip socks, and a night light. Keep your glasses and hearing aids within reach. These simple steps prevent the 2 a.m. sprint that ends in a fall. If the team worries about incontinence, propose briefs or a commode at the bedside as a short-term bridge while you rebuild strength. A commode beats a catheter every time for infection and delirium risk. And remember, if you do need a catheter briefly for surgery or strict output, set the removal target at the time it's placed. Say, let's plan removal tomorrow morning and reassess with a bladder scan. Here's a quick micro story. An 82-year-old admitted for pneumonia arrives walking with a cane. The night shift places a Foley so he can rest. By day 3, he's confused and pulling at lungs. He's labeled unsafe to ambulate, and rehab becomes the plan. In a parallel case, the Foley is refused. They scan his bladder twice, schedule toileting, sit him up for meals, and walk him to the door with a gait belt 3 times daily. No infection, no delirium. He discharges home with a walker and home PT in 2 days. Where most people slip is thinking they must wait for PT to move. You don't. Ask the nurse or aide for a supervised sit to stand, a transfer to the chair, and short walks. Log each one. If pain holds you back, treat the pain not with sedation, but with timed analgesia before activity. If shortness of breath limits you, sit up, use the incentive spirometer hourly while awake, and try again later. Seal it with 3 lines from your shield. What's our goal? No Foley unless retention, surgery, or strict output. Up to chair for meals. Walk 3 times daily. Say them early, repeat them at shift change, and watch how the trajectory changes. Mobility is medicine. Catheters are not. Mistake number 3, the nighttime sedative swap. You did the hard work. You kept moving. You dodged the catheter. You asked smart questions about scans. Then night hits. A well-meaning nurse offers just 1 dose to help you sleep. This is where many strong hospital stays go sideways. In older adults, sedatives like benzodiazepines and Z-drugs don't just make you drowsy. They scramble balance, slow reaction time, fog judgment, and spiked delirium. In several hospitals, over half of patients who fell had one of these meds on board that night. That's not a scare tactic, it's a pattern. And the fallout is real: a broken hip, a rapid response call, or a new antipsychotic layered on top for agitation. Suddenly, you're too groggy to walk with therapy in the morning, and discharge slips from tomorrow to next week. Why does this happen so often? Night shifts are stretched thin. Alarms, vital checks, and roommate noise make sleep hard. Writing for a pill feels faster than fixing the environment. Add the myth that it's only one dose, and the trap is set. But for older brains, a single dose can linger into the next day. Longer-acting drugs stack up. Antihistamines like diphenhydramine or hydroxyzine carry anticholinergic effects that worsen confusion. Zolpidem can unmask sleepwalking or balance issues at 2 a.m. Benzodiazepines, cloud memory, and coordination. None of these help you pass tomorrow's PT walk test. Here's the pivot: trade sedation for a sleep bundle. You'll sound practical, not demanding. Say, "Can we try the sleep bundle first?" Then list what works: lights down, hallway noise minimized, a warm caffeine-free drink, bathroom trip before lights out, your own blanket or socks, relaxation audio through your phone, and low-dose melatonin only if needed. Ask the team to cluster care, vitals, meds, and labs so you aren't woken every hour. Request a door sign: quiet hours, cluster care. Ask for a white noise machine or a fan hum if available. These steps are guideline-backed in ICU and medical units because they cut delirium without drugs. If pain is the real reason you can't sleep, treat pain precisely. Ask, "Can we time my pain medicine 30 to 60 minutes before lights out?" Short-acting analgesics, heat packs, and positioning beat a sedative every time. If anxiety is the driver, ask for reassurance. "Can we review tomorrow's plan now, so I'm not spinning?" Breathing drills, a brief call with your advocate, or moving an evening diuretic earlier can remove the cause without knocking you out. Use your Shield's medication line to make boundaries clear. Avoid diphenhydramine, hydroxyzine, lorazepam, and zolpidem. Add the sentence that pauses most orders: "I'm high risk for delirium." No sedatives unless ICU-level reason. If a clinician believes a sedative is essential, ask for specifics: the goal, the dose, and the stop date. Then document the morning consequence. If any sedative is given, I need a supervised step test with staff before walking alone tomorrow. That prevents the classic morning fall from residual drug effects. Now, let's address pushback. You may hear, "Melatonin doesn't work for everyone," or "We use a low dose of trazodone." Keep it collaborative. If non-drug steps fail, what is the lowest risk option we can try with the smallest dose and a one-night limit? In some units, melatonin or gabapentin at low dose is preferred over benzos or Z drugs. The key is a one-night trial with a plan to reassess at sunrise. No auto-renewals. A quick micro-story to anchor this. A 79-year-old woman admitted with a mild infection was walking to the chair and eating well. At midnight, she couldn't sleep. A resident ordered zolpidem. At 5 a.m., she woke groggy, stood without pressing the call button, and fell. Morning PT was canceled, and discharge slid 2 days. In a parallel case, the nurse used the sleep bundle, moved a late diuretic to late afternoon, dimmed lights, and cued soft audio. The patient slept 4 hours, woke clear, walked 60 feet with point at 9 a.m., and went home the next day. One more pattern people miss: screens and timing. Ask to avoid vitals or lab draws between midnight and 5 a.m. when safe. Keep your phone in night mode after 9 p.m. Blue light delays sleep. If you share a room, request a sleep mask and earplugs. If alarms are frequent, ask staff to place louder devices outside your doorway. Seal this section with 3 scripts from your Shield. What's our goal? Sleep or safety? Can we do the sleep bundle first? I'm high risk for delirium. Please avoid benzos, Z-drugs, and anticholinergics. If any sedative is given, I need supervised walking tomorrow morning. Night is when your plan either holds or cracks. Hold the line politely. You'll wake clearer, mistake number 4, and go home weekend faster. Delay, discharge, stall. You've protected your nights. Now the calendar can work against you. The quiet trap is the Friday test with a Monday result, a lab, an ultrasound, a stress test ordered late Friday, often sits untouched until the weekday team returns. That turns one stable weekend into 2 extra hospital days, 2 extra nights of bad sleep, 2 more chances for a sedative, a line infection, or a fall. And if your status is observation, those days cost you cash without counting toward Medicare's 3 inpatient midnights. Function erodes while the system idles. This isn't about blame, it's about momentum. Discharge is a project. Projects stall when the owner isn't in the room. So you become the owner politely, daily, and especially on Thursdays and Fridays. Here's the fix, and it starts every morning by 9 a.m. Ask, what gets me home today? Then ask the nurse to write the blockers on the whiteboard. Unstable vitals for meds not converted to pills, no safe walk yet, bathroom independence not proven, no home oxygen arranged, no family support confirmed, no follow-up booked. When the blockers are visible, the team can knock them down. If nothing is on the board, press for specifics. Which single action, if done before noon, moves my discharge forward? Use a daily discharge checklist you can say out loud. Stable vitals on room air or a confirmed plan for oxygen at home. Pain controlled on oral meds with a clear schedule. Oral intake adequate. For fluids stopped. Walk 50 to 100 feet with a device as needed and supervision. Transfer to chair independently or with safe assist. Toilet with safe assist. No new catheter. Scheduled toileting at night. Home medications reconciled with stop dates for anything started inpatient. Follow-ups scheduled within 7 to 14 days. Prescriptions e-prescribed to your pharmacy. Home health, equipment, or caregiver support arranged if needed. Then time matters. On Thursdays, add this line: we want to be home by Friday. What needs to be finished today to avoid a weekend delay? If a test is proposed on Friday that doesn't change weekend management, ask to move it up or convert it to outpatient. If the answer is the specialist needs to weigh in, request a same-day curbside call. Could the hospitalist speak to cardiology now and agree on an outpatient plan? Many stalls are solved by a 5-minute phone call instead of a Monday consult. Here's where you separate from the crowd. Pre-schedule everything before Friday noon. Ask case management to book. A primary care follow-up in 7 to 14 days for medication reconciliation and deprescribing. Any critical specialty follow-up within 1 to 2 weeks. Home health nursing or PT/OT if mobility, wound care, oxygen, or new meds require support. Equipment delivery today. Walker, shower chair, commode if needed. If you hear the earliest home health visit is Monday, ask for a bridge. Can we teach us wound care before discharge? And send the first nurse visit Tuesday. If equipment is delayed, ask for a loaner from the hospital stock. Small bridges keep you out of a skilled nursing facility you don't need and prevent a $10,000 to $50,000 rehab bill if you lack 3 inpatient midnights. Now, the weekend rule. If it's Friday and you're close, deploy the 48-hour plan. If we're not ready by tomorrow morning, please escalate to the case manager and charge nurse today. What is the single blocker we can solve before 3 p.m.? This pulls resources while weekday staff are still here. If the blocker is waiting on a lab, ask, can we draw it stat? If it's switch 4 to oral, ask the doctor, can we trial oral meds now and monitor before evening? If it's PT needs to clear, request a mobility test with nursing using your walker and gait belt. Document the walk distance and assistance level. Many clearances are functional, not mystical. Use 3 scripts to keep momentum. What's our home by date and what blocks it? Can we finish the items that would delay me over the weekend today? If not today, who can help remove this blocker within 24 hours? Be proactive with medications. Ask to convert 4 antibiotics to oral forms if you're clinically improving and absorbing food. Many common antibiotics have oral equivalents with near-identical effectiveness. Verify that blood thinners, diabetes meds, and heart meds are timed for home routines. If a new drug was started inpatient for a temporary reason, like a PPI for stress ulcer prevention, ask for a stop date and a discharge summary, note explaining when to taper or stop. Transportation derails many Friday discharges. Solve it early. Confirm your ride time. If you need an ambulance for safety, have case management schedule it before lunch. If not, arrange a family pickup that matches medication and therapy times. Don't let a 4 p.m. ride issue become 2 extra nights. A quick micro story. A 76-year-old with heart failure stabilized by Thursday. The team ordered a Friday echo for baseline, which would not change weekend care. The advocate asked, "What gets him home today?" Blockers were oral diuretics trial, a hallway walk, and oxygen setup. They completed all 3 by 2 p.m. The echo was scheduled outpatient for Tuesday. He slept in his own bed that night. In the near-miss version, the Friday echo bumped to Monday, 2 more sedated nights, and a Monday fall canceled PT. Discharge slid to Wednesday. End with your shield line. What's our goal? If the goal is home, align every order to that. When the goal is clear by 9 a.m., weekends stop being a trap and become a finish line. Mistake number 5, the new forever med that never stops. You're almost out the door when a quiet mistake slips into your bag. A new medication that was meant for the hospital, not your life. It happens because inpatient problems demand quick fixes. But no one sets a stop date. A stomach pill to prevent stress ulcers, a nighttime antipsychotic for one confused evening, sliding scale insulin for temporary high sugars. Then you're home, still taking them, and weeks later you're dizzy, weak, constipated, or falling. This is how hospital meds turn into forever meds without anyone saying, "We meant 2 weeks, not 2 years." Here's what's most likely to stick by accident. Proton pump inhibitors, the purple stomach pills, get started for stress protection while you're NPO or on steroids. Antipsychotics appear during a rough delirium night. Sliding scale insulin shows up when infection or 4 steroids spike glucose. Sleep drugs sneak into the bedtime list even after the cause is gone. Each of these has a cost. Long-term PPIs can raise risks for C, diff, fractures, and nutrient issues. Antipsychotics can slow thinking, stiffen movement, and increase falls. Sliding scale insulin without a plan leads to dangerous highs and lows. And we already covered sedatives at night. So you need one clean process before you leave: medication reconciliation with stop dates. Use your hospital shield and ask the team, "Can we walk through every medication I'm being discharged with and label a keep, taper, or stop?" Put it in writing on the discharge summary so your primary care clinician sees the plan, not just the list. Here's the simple flow that works on busy wards. Step 1, sort by purpose. For every new med, ask, "What problem did this start for?" If the answer is hospital only, you likely don't need it at home. If it's preventive while you were NPO, that's a stop. If it's for confusion, that's a taper and stop as delirium clears. Step 2, set a default stop date. For PPIs started inpatient without a known ulcer or GI bleed, set a 2-week stop unless you have reflux symptoms returning. For antipsychotics used for delirium, set a 1-week taper-off plan with a check-in call if confusion lingers. For sliding scale insulin added because of infection or steroids, write a plan. Stop the scale when steroids finish and sugars normalize, or convert to a simple home regimen with a follow-up in 7 days. Step 3. Write the why sentence on your paperwork. Add, PPI started for stress only, stop 2 weeks after discharge if no reflux, or quetiapine used for delirium, taper off over 7 days. Do not refill without reassessment. That single sentence prevents automatic refills. Step 4. Book the deprescribing visit. Before you leave, ask case management to schedule a primary care or geriatrics visit in 7 to 14 days. Bring the hospital medication list and your shield. The visit goal is to remove what you don't need, simplify timing, and tighten doses that were started high in the hospital. Use scripts that keep everyone aligned. Which of these meds were started only because I was inpatient? What symptom returns if we stop this in 2 weeks? Can we put a stop date or taper plan in the discharge summary? Is there a lower risk option for this same goal? Let's apply it to the high-risk trio. Antipsychotics for sundowning. These are meant for dangerous agitation that doesn't respond to non-drug steps. If they were used, ask for the trigger that prompted them and how it's now resolved. Lock a taper plan before you leave. At home, double down on delirium defense. Glasses, hearing aids, daylight, hydration, sleep bundle. If confusion returns, call early. Don't restart a drug on your own. PPIs for stress. If you needed them while critically ill or NPO, fine. But at discharge, ask, do I have a diagnosis that needs this long-term? If not, stop in 2 weeks. If reflux returns, try step down. Timing meals, avoiding late-night eating, elevating the head of bed, or using an H2 blocker short-term while you reassess. Sliding scale insulin. If steroids or infection raise sugars, the fix is removing the cause and checking fasting values at home. Ask for a meter, strips, and a simple plan. Targets when to call and when to stop the scale. If you already take diabetes meds, confirm how the new plan fits your home regimen and meals. 2. More quiet add-ons to watch. Blood thinners and antibiotics. If a blood thinner started for a short-term clot risk, ask for the stop date and the exact duration. If antibiotics were 4 in the hospital, confirm the oral switch and the shortest effective course. Long courses, add C. Diff risk without more benefit. A quick micro story to anchor it. A 74-year-old man received a PPI just in case while on 4 steroids. He went home still taking it, grew constipated, ate less, got weaker, and ended up back in the ER with dizziness. In the parallel case, the team labeled the PPI stress only and stopped it at 2 weeks. They set a deprescribing visit, reviewed meds, and tightened his blood pressure timing. No bounce back, no new pills. Seal this with your shield phrases. What's our goal? Medication reconciliation with stop dates. Keep taper, stop, let's label each one. Get it on paper, teach your advocate the plan, and book the follow-up before you leave. Preventing a forever med is one of the fastest ways to protect your brain, your balance, and your budget. The 14-day muscle crash. Stop it cold. Here's the truth most discharge summaries ignore. Muscles in older adults don't rest and recover in a hospital bed. They shrink and weaken at warp speed. 2 weeks flat can cost up to about 20% of strength, roughly 1 to 1.5% per day. That turns curbs into mountains, bathrooms into obstacle courses, and a short hallway into a marathon. The crash targets legs first, the engines for standing, stair climbing, and balance, so falls spike right when you're already tethered by lines, new meds, and lousy sleep. The solution isn't fancy equipment. It's a simple, daily plan that starts at the bedside and follows you home. Start with fuel. Hospitals often underfeed protein, and older bodies are anabolically resistant, which means you need more quality protein to get the same muscle-building signal. Aim for about 30 grams of protein at each meal. Think easy to chew, leucine-rich choices. Greek yogurt, cottage cheese, eggs, tuna, or chicken salad, tofu, whey protein shakes, or soft lentils. If appetite is low, go dense and simple. A half shake plus a boiled egg meets the mark. Add color for recovery, berries, cooked veggies, and soups without overfilling on low-protein sides. Ask the dietitian to write 30 g protein per meal on your tray ticket. When it's in the order, it appears on the plate. Now, pair fuel with hospital-safe moves you can do even within 4 and monitors. These aren't gym workouts. They're precision drills to keep the legs online. Sit to stand. From a chair with arms, stand up and sit down slowly. Target 5 to 10 reps, 2 to 3 times daily. If you need help, press through the chair arms or have staff steady your gait belt. Each rep is a deposit back into your quads and glutes. Marching at the bedside. Stand holding the chair or walker. Lift one knee, then the other. Start with 20 total marches. This trains hip flexors and balance without walking laps. Heel raises. Stand, hold support, rise onto your toes, pause, lower. Do 10 to 15 reps. Calves are your push-off muscles for steps and getting out of chairs. Long arc quads. From the chair, straighten one knee, hold 2 seconds, lower. 10 reps per side. This keeps your knee extension strong for safe transfers. Ankle pumps. In bed or chair, flex and point your feet for 30 seconds each hour while awake. This supports circulation and reduces clot risk when you're less mobile. Dosage matters. Anchor 2 mini sessions to meal times, after breakfast, and after lunch when you've got calories on board. Add a light evening session if energy allows. Ask nursing to chart these reps next to ambulation, like vital signs. When it's on the board, it gets done. Layer in walking the smart way. After vitals and a bathroom trip, request a supervised hallway walk. Start with the distance to the door and back. Build to 50 to 100 feet with a device and assist as needed. If dizziness or shortness of breath shows up, pause, sit, and treat the cause: hydration, orthostatic blood pressure checks, timed pain meds, then try again later. Progress beats perfection. If you're tethered to a line, use the "can we remove it today" script. If not yet, ask for a portable pole and a clear path. Hydration and bowels are not side quests. They're muscle insurance. Dehydration and constipation sap appetite, stall activity, and spike delirium. Aim for regular sips, a fiber plan that won't bloat you, cooked oats, prunes, or a gentle supplement, and a scheduled bathroom trip every 2 to 3 hours. Pair toileting with a short walk and a hand wash. That's 3 wins in one transit. Post-discharge, upgrade to a simple 14-day rebuild that fits in a small living room. 3 days per week, strength circuit, sit to stands, heel raises, step-ups onto a low step or sturdy book, and a gentle row with a resistance band. 2 sets of 8 to 12 reps daily. A 10 to 20-minute walk, broken into chunks if needed. Focus on posture. Eyes up, short steps, steady breathing. Use your device proudly. It's a bridge, not a failure. Balance micro drills. Heel-to-toe stance at the counter, gentle single leg stands with a fingertip on the surface, and slow head turns while standing tall. 10 to 30 seconds per position, twice daily. Keep protein at 30 grams per meal, add a shake after strength days, and salt lightly if blood pressure allows to support volume. If you're on diuretics, confirm timing so you're not sprinting to the bathroom mid-walk. Wear the right shoes, clear floor clutter, and light hallways. Common mistakes to avoid. Saving exercises for when PT comes, doing all reps in one marathon, skipping protein at breakfast, and stopping after a tired day. The fix is rhythm, small, frequent deposits. Use your shield scripts to protect the plan. Up to chair for meals, walk 3 times daily. And what's our goal? If the goal is legs that get you home and keep you there, this is how you pay your muscles first. Every single day. Delirium defense. Keep your mind online. Now let's protect your most important organ, your brain. Delirium is a sudden change in attention, thinking, and awareness. It can look like confusion, agitation, or unusual sleepiness. Older adults are high risk in hospitals because infections, new meds, poor sleep, dehydration, pain, and tethers pile up fast. The goal here is simple. Keep your mind online by reducing the triggers, spotting early signs, and fixing causes before someone reaches for a sedative. Start with anchors that keep your brain oriented. Glasses on during the day, hearing aids in and working, dentures seated for meals. Ask staff to label cases and place them within arm's reach, not locked in a drawer. Pull back the curtains in the morning for daylight and close them at night. Keep a large face clock and a calendar visible from the bed. Ask staff to state the day, place, and plan at each interaction. It's Tuesday morning on 4 West. We're walking after breakfast. These tiny cues reduce misfires. Next, build a daily check for delirium so it's not missed. Ask the nurse or doctor for a CAM screen, the confusion assessment method, once per day, then say the line that moves action. If there's any change, please look for causes first: pain, infection, constipation, urinary retention, low oxygen, low sugars, or new meds. Delirium is often a signal, not a diagnosis. Treating the signal without finding the cause is how cascades start. Remove common sparks. You already set no benzos, Z-drugs, or anticholinergics on your shield. Add a medication review for hidden offenders, diphenhydramine in sleep or cold combos, hydroxyzine for itch, promethazine for nausea, oxybutynin for bladder, high-dose gabapentin, and antipsychotics used as first line. Ask, is there a non-sedating alternative? For nausea, try on Dancitron. For itch, moisturizers, or low-dose cetirizine daytime only. For bladder urgency, scheduled toileting beats, anticholinergics in the hospital. Hydration, food, and bowels matter. Dehydration lowers blood pressure to your brain. Aim for steady fluids unless restricted. Ask for a water bottle in reach and a sip schedule. Protein at each meal helps energy and recovery. Constipation is a delirium trigger. Set a simple plan on day 1, fiber you can tolerate, stool softener, and a rescue option if no result by day 2. Pair toileting with a short, supervised walk to keep momentum. Night is prime delirium time. We swapped sedation for a sleep bundle. Now deploy it fully. Request quiet hours posted on your door, lights dimmed, clustered vitals, and a warm, caffeine-free drink before bed. Keep your glasses and hearing aids close, but in a safe case. Ask for a warm blanket. Use your own playlist or a hospital relaxation track for 15 minutes. If you wake, press the call button before getting up. A sleepy stumble is a fall waiting to happen. Tethers fuel confusion. Each line, restraint, or alarm can push agitation. Use the script daily. Can we remove it today? For IVs used once daily, ask to place them after dinner and remove them by morning if safe. Replace bed alarms with a sitter, family presence, or a chair alarm while supervised. If a sitter isn't available, ask for the chair near the nurse's station during the day. Movement plus supervision beats restraint every time. Family and advocates are a delirium shield. Ask your person to visit during daylight hours for orientation, meals, and a short walk. Give them 3 jobs. Bring in label glasses and hearing aids. Read the day's plan aloud, and ask the scripts at decisions. A familiar voice lowers stress hormones and reduces misinterpretation of hospital noises. Pain and breath drive restlessness. Untreated pain can look like agitation. Ask for a -10 pain check with a plan to pre-medicate before therapy and bedtime. Low oxygen scrambles thinking. Request pulse ox checks with mobility and after bathroom trips. If numbers dip, fix the cause. Sit up, use the incentive spirometer 10 slow breaths each hour while awake, and review lung treatments. If delirium appears, hold the line on non-drug first. Re-anchor orientation, treat pain, fluids, bowels and infection, remove tethers, optimize sleep, and keep a calm, well-lit room by day and dark by night. If safety is still at risk, discuss the narrowest drug, smallest dose, and shortest time with a sunrise stop. Document the plan in the chart and on your whiteboard. After discharge, keep a 2-week watch. If new confusion or attention problems show up at home, call your primary care or geriatrics office early. Bring the hospital med list. Ask, which can we taper or stop now? Then reapply the basics: daylight, movement, hydration, protein, sleep routine, and your glasses and hearing aids on first thing every morning. Keeping your mind online is not infection. It's a set of habits you control. Lines, lungs, and bathroom. You've protected your muscles and your mind. Now we shut down the 3 quiet infection sources that keep people in beds longer than they need: lines, lungs, and the bathroom. Infections don't just add antibiotics. They add delirium, bed rest, new meds, and sometimes a bounce-back admission. This section is pure prevention you can say out loud and track on the whiteboard. Start with lines. Every tube is a doorway for bacteria. IVs, central lines, urinary catheters, feeding tubes, even oxygen humidifiers when mismanaged. Use one script every morning. Can we remove it today? Ask why each line still exists and what has to change to remove it tomorrow, if not today. For a peripheral 4 used once daily, propose a short reinsert window before the next dose and removal after. If you're on oral meds, ask to pull the 4 entirely. For central lines, request a daily necessity check with a plan to de-escalate. If there's a port or PICC, just in case, ask for criteria to switch to oral therapy. The moment a line leaves, your risk drops. Hand hygiene is your force field. Make it normal and kind. Please gel in. Say it to every person who touches you or your environment, including family. Keep sanitizer within reach. Ask staff to clean high-touch surfaces. Bed rails, call button, tray table. During each room, tidy. If you cough or sneeze, sanitize after tissues. Small habits cut transmission chains. Now lungs, the most underused organ in the hospital. Shallow breathing from pain, sedation, or fear lets mucus sit and bacteria move in. 2 tools fix this: position and practice. Sit up for all meals and for at least 1 hour after. Ask for the head of bed at 30 to 45 degrees, not flat. Use your incentive spirometer, 10 slow, deep breaths every waking hour. Aim to raise the ball to your best level and hold for a gentle pause at the top. Log your best number on the whiteboard. It turns into a game. You can win. Pair each walking session with a breathing set. Walk, then 10 breaths. Cough and clear after breathing drills. Request a splinting pillow to press to your belly or chest for support if there's pain. If pain blocks deep breaths, time analgesia 30 to 60 minutes before breathing practice and walking. If you're on oxygen, ask for checks during activity and wean trials while seated when safe. If secretions are thick, ask for humidification review, warm fluids, and chest physiotherapy if ordered. Mouth care twice daily, brush, swab, or rinse reduces the bacterial load you might inhale. The bathroom is the sleeper category. A catheter is an infection shortcut, so you've already pushed to avoid or remove it. Now prevent the problems that lead staff to suggest one. Set scheduled toileting every 2 to 3 hours while awake and before sleep. Ask for assist on a cadence, before meals, after meals, and at lights out. Keep a clear path. No cords on the floor, non-slip socks or shoes on your feet, and a nightlight on. If urgency or incontinence is an issue, request a bedside commode rather than a catheter. Pair each bathroom trip with hand washing or sanitizer and a brief supervised walk. Pericare matters. After toileting, ask staff to assist with gentle front-to-back cleaning and thorough drying, especially if you're using briefs or pads. Skin breakdown invites infection. If moisture is frequent, Request barrier cream and regular checks to keep skin intact. Keep wipes and gloves at arm's reach so aides and family can help consistently. Hydration supports all three systems. Steady fluids keep mucus thin, bowels moving, and urine flowing. If you're fluid restricted for heart or kidney reasons, confirm your target and spread sips across the day. Track intake on the whiteboard. For bowels, a simple plan from day one: fiber you tolerate, stool softener, and a rescue option if no movement by day 2 prevents straining, urinary retention, and confusion that lead to bad choices like catheters or sedatives. Here's a quick daily checklist you can say on rounds. Can we remove any lines or alarms today? Sat up for all meals, 2 walking sessions logged, spirometer hourly while awake, scheduled toileting active, commode available, pericare and hand hygiene done. Red flags after discharge are your early catch net. Call if you notice fever, chills, new cough or sputum, increasing shortness of breath, wound redness or drainage or burning, urgency or cloudy urine. Don't wait for it to pass. Early calls prevent late nights in the ER. Close this loop with your 3 words. What's our goal? If the goal is home, then today's moves are line removal, lungs working, and safe bathroom trips. Say the scripts, log the actions, and you cut the infection path at every turn. Billing shield, observation versus inpatient, and the 3-day rule. You've tightened safety and momentum. Now protect your wallet. In hospitals, your status is not a feeling, it's a billing category that decides what Medicare pays. There are 2 main buckets: observation and inpatient. Here's the twist: most people don't learn until the bill arrives. Observation can look and feel exactly like a hospital admission. The same bed, the same nurses, the same tests, but it's classified as outpatient. Under Medicare, observation days do not count toward the 3 consecutive inpatient midnights required for rehab coverage. Miss that threshold, and a short skilled nursing rehab stay can dump a $10,000 to $50,000 bill on your doorstep. That's not a mistake, that's policy. So you need 1 daily question, starting day 1. What is my status today, observation or inpatient? And why? Ask the nurse and the doctor, and request the written Medicare status letter. If your observation, do 2 things immediately. First, ask what clinical criteria are missing for inpatient. Second, document symptoms and needs that show inpatient-level care. Oxygen requirements for medications that have no oral equivalent yet. High fall risk needing frequent supervised mobility, unstable vitals requiring telemetry, or active treatment changes overnight. Clear, specific documentation helps your physician justify an inpatient order. If you clinically meet criteria, politely push for conversion to inpatient before midnight. Say, given my oxygen needs and 4 therapies, do I qualify for admission today? If the answer is not yet, ask, what is to change so I qualify? What labs, what stability, what treatment? Get those targets on the whiteboard. If you're stable and observation is appropriate, that's fine. Just don't let anyone suggest rehab from observation unless you're prepared to self-pay. Now, build guardrails for discharge planning. Before anyone mentions rehab or a skilled nursing facility, confirm the 3 midnight rule. Do I have 3 consecutive inpatient midnights? Midnights matter, not hours. If you have 2 inpatient nights and 1 observation night, it doesn't count. Ask case management to verify in writing and provide your status summary. No 3 midnight string? Pivot the plan. Home with services. Request accelerated home health equipment delivery today and the earliest outpatient therapy slot. Home with services protects your function and your finances. Watch for a common stall. Let's send you to rehab for a few days to get stronger. That sounds supportive, but without those 3 inpatient midnights, Medicare will not cover the facility stay. Make the math explicit. Do I have 3 inpatient midnights? If not, we prefer home with services. If you do have 3 midnights and need skilled rehab, proceed. But still ask about alternatives, expected length of stay, and the plan to get back home fast. Status can change. If you start as observation, meet criteria, and convert to inpatient, the clock starts when the inpatient order is written, not when you arrived. Track it. Night shift counts. Ask the team to write the order before midnight if criteria are met, so the calendar doesn't push you into another day. 2 more money savers. First, get an itemized bill. After discharge, compare it to your records. Challenge duplicate labs, never given meds, and services you declined. Hospitals correct real errors, especially when you're specific. Second, ask daily, are any tests or consults low value for my discharge goal? A Friday baseline, echo that won't change weekend care, is a Monday bill you don't need. Convert it to outpatient, where copays are often lower and scheduling is faster. Here's a tight micro story. An 80-year-old admitted Friday as observation for dizziness received 4 fluids, telemetry, and supervised mobility. On Saturday morning, the advocate asked, "Status today?" Still observation. They documented orthostatic drops, fall risk, and need for supervised ambulation and telemetry. The physician converted to inpatient at 4 p.m. Saturday. By Monday morning, they had 3 inpatient midnights and safely discharged to short rehab, fully covered. In the near-miss version, no one asked about status. Rehab started from observation Sunday, and a $14,800 bill arrived. Seal this with 3 scripts from your shield. What is my status today? Observation or inpatient? And why? If observation, what criteria are missing for inpatient, and can we document them? Before any rehab transfer, do I have 3 consecutive inpatient midnights? Please provide the status letter. Status isn't paperwork, it's protection. Ask early, ask daily, and align every order to the goal that keeps you safe, mobile, and financially intact. The 3 words and 5 scripts that save you. You've seen the traps and the fixes. Now you need language that works at 6 a.m. on a busy floor and at 10 p.m. when you're tired. The core is 3 words. What's our goal? Say it before any test, med, line, or discharge decision. It reframes the moment from tasks to outcomes, home, function, and safety. Everything else hangs on this anchor. Script 1. Will this result change treatment today? Use it for scans, labs, consults, and baseline tests. When the answer is no or probably not, ask for the time box, watchful waiting with repeat vitals and targeted rechecks. Tie it to action. If not today, let's schedule this outpatient. This single question cuts incidentalomas, needless overnights, and bed rest. Script 2. What's my home by date and what blocks it? Use it by 9 a.m. daily. Get blockers on the whiteboard. 4 to oral conversions. Safe walk not documented. Oxygen setup. Follow-ups missing. Then ask, which one action before noon moves me closer? Momentum builds when blockers are visible and owned. Script 3. Can we remove it today? Aim it at lines, catheters, restraints, bed alarms, and even telemetry. If removal isn't safe, ask, what needs to change so we remove it tomorrow? Get the condition in writing. Finish 4 antibiotics, stable heart rhythm, successful oral meds. Tethers fall faster when criteria are explicit. Script 4. I'm high risk for delirium. Safer option? Use it to deflect benzos, Z-drugs, anticholinergics, and heavy nighttime sedatives. Offer the swap, sleep bundle, timing pain meds, low-dose melatonin, gabapentin only if appropriate, and a 1-night trial with a sunrise stop. Add the safety rider. If any sedative is given, I need supervised walking tomorrow. Script 5. Please gel in. It's short, kind, and consistent. Say it to everyone, every time. Pair it with, we're tracking line removal and lung exercises on the board, so staff see you're engaged in prevention, not policing. How to use scripts without friction. Pick a lead voice. Your advocate is the first speaker. You back them up. Nurses juggle a lot. One calm, consistent voice gets better results than a chorus. Stack the questions. Start with what's our goal? Then add the relevant script. Example at 10 p.m. What's our goal? Sleep or safety? I'm high risk for delirium. Can we do the sleep bundle first? Keep tone neutral and specific. Replace, I don't want that, with will this change treatment today? Replace, take this out, with can we remove it today? If not, what has to change by tomorrow? Close the loop in writing. Ask to put decisions on the whiteboard and in the note. The time box instead of a scan, the catheter removal target, the discharge blockers list, the sedative one-night limit, the status letter for billing. Use timing to your advantage. Big requests go in early rounds when decision makers are present by late afternoon Friday. Ask, what must we complete before 3 p.m. to avoid a weekend delay? Common pushbacks and responses. It's protocol. Say, understood. If it won't change treatment today, can we follow protocol as outpatient? It's just one dose. Say, I'm high risk for delirium. Lowest risk option, smallest dose, one night, and supervised walking tomorrow. Let's keep the line, just in case. Say, can we plan to reinsert if needed and remove it now to lower infection risk? Rehab will get you stronger. Say, do I have 3 consecutive inpatient midnights? If not, home with services, please. Retention checkpoint. If you remember nothing else, carry the 3 words and these 5 scripts on your shield. Take them to your phone case. Put them on the room whiteboard. Teach them to your spouse or friend. Used together, they redirect the system from convenience to outcomes, prevent the 70% drop-off in function that crushes independence, and save you from surprise bills and avoidable falls. This is how you turn a chaotic stay into a guided path home. Micro stories. 3 fast wins using this playbook. Story A starts in a crowded ER on a Tuesday evening. A 78-year-old woman arrives with brief chest pressure after climbing stairs. In triage, she's calm, pain-free, vitals steady. The default order set includes a CT pulmonary angiogram and admission under observation. Her daughter takes out the hospital shield and leads with the 3 words, what's our goal? The physician says, rule out heart attack and make sure she's safe to go home. They agree on serial EKGs and 2 troponins over 3 hours, both normal. The advocate stacks scripts. Will this result change treatment today? Could we watch for 6 hours with repeat checks? They add a supervised hallway walk and a sit-to-stand test. No scan, no dye, no midnight transport. By 10 p.m., she's home with an outpatient stress test booked. The bill difference? They avoided a $7,400 observation stay and the incidentaloma cascade that follows contrast imaging. The win wasn't luck. It was pausing the reflex and proving stability with targeted monitoring and function. Story B opens on a medical floor at 1 a.m. An 83-year-old man admitted for pneumonia is dozing when a nurse suggests a Foley so he can rest. His spouse, coached earlier, says, no Foley unless retention, surgery, or strict hourly output. Can we bladder scan first? The scan shows a modest volume. They set scheduled toileting every 2 to 3 hours, keep a commode at bedside, sit him up for meals, and walk to the door with a gait belt 3 times daily. The line removal script shows up each morning. Can we remove it today? By day 2, he's off 4 fluids and walking 80 feet with a walker. No catheter means no UTI. No UTI means no delirium. With infection risk down and mobility up, he discharges home on day 3 with home health and a clear antibiotic plan. In a near-miss version, the Foley stays, a UTI blooms, confusion follows, and skilled rehab replaces home, with a 5-figure bill if he lacks 3 inpatient midnights. The shield blocked that domino run. Story C begins at discharge. A 74-year-old with a short admission for cellulitis improved quickly, but had one agitated night. A resident added an antipsychotic and a PPI just in case. The advocate sits down with the team. What's our goal? Safe home, clear head, no bounce back. They request medication reconciliation with stop dates. The antipsychotic is labeled for delirium only with a 1-week taper-off plan and a big note, do not refill without reassessment. The PPI is tagged stress only, stop in 2 weeks if no reflux symptoms. They schedule a 7-day primary care visit to deprescribe. At home, his glasses and hearing aids are on, daylight routine is tight, protein hits 30 grams per meal, and he walks daily. Clarity returns, no falls, no constipation spiral, no new forever meds. In the parallel universe, those 2 drugs keep running. He grows groggy and weak, misses PT sessions, stumbles, and lands back in the ER. The difference was 4 questions and 1 appointment on the calendar. What's the pattern across these wins? The same tiny moves, repeated. The 3 words before any decision. Will this result change treatment today? No Foley unless a real indication. Can we remove it today? I'm high risk for delirium. Safer option? Then the Friday accelerator. What's my home by date? And what blocks it? Mix in billing awareness. What is my status today? And do I have 3 consecutive inpatient midnights before any rehab talk? And you steer care to outcomes, not tasks. Here's the what if. Apply these scripts in your next hospitalization. Your retention graph, the one that usually drops at night, on weekends, and after new meds stays flat or even climbs. Instead of losing 1 to 1.5% strength per day, you bank deposits through sit-to-stands, hallway walks, and protein at each meal. Instead of a mystery bill, you hold a status letter and an itemized statement that matches what you received. Instead of a scatter of new pills, your discharge list is clean, labeled keep, taper, or stop. The result isn't just fewer days in a bed. It's walking back into your own kitchen on your own legs with your mind clear and your money intact. The 3-step action plan. Step 1, print your 1-page hospital shield today. Fill in meds, allergies, baseline function, code status, and your advocate's contact. Add your goals. Home walking like before, no new catheters, avoid benzos and Z drugs. Put copies in your wallet, phone, and glove box. Step 2, memorize the 5 scripts and teach them to your advocate. What's our goal? Will this result change treatment today? What's my home by date? And what blocks it? Can we remove it today? I'm high risk for delirium. Safer option? Tape them to your phone case. Step 3, build a 14-day strength and brain routine you can start in any room. 30 grams of protein per meal, sit-to-stands, heel raises, marching, spirometer hourly while awake, daylight by day, sleep bundle by night. Do this now and you'll cut bed days, new meds, and surprise bills. You've moved from passive patient to prepared partner, someone who blocks the 5 traps that quietly steal strength, clarity, and cash. Your 3 words set direction. Your 5 scripts align care with getting home, walking safely, and avoiding low-value tests, tethers, and sedatives. Your shield turns chaos into a plan. Your challenge this week: carry the shield everywhere and use what's our goal at least once a day at a clinic visit before a test or when a new med is suggested. Track 1 win on your phone. A line removed, a scan deferred, a nighttime sleep bundle instead of a pill. Ready to lock this in? Watch the Delirium deep dive. Next, to master the family playbook for calm, clear nights, then jump to the 14-day strength rebuild to protect your legs. Do this now and you protect up to $50,000, keep your independence, and safeguard your brain. Starting today,